And the speaker is Dr. Tarek Tantawy. He is originally from Egypt, but working in Saudi Arabia. He is consultant of Cardiac ICU, Deputy Program Director of the Cardiac Critical Care Fellowship, and he's working currently in Prince Sultan Cardiac Center in Riyadh in Saudi Arabia. The talk of Dr. Tarek is the management of heart-beating brain death organ donor, and we are welcomed Dr. Tarek. You can go ahead and you can share your slide, Tarek.
We'll be speaking about the management of brain dead organ donors.
Yes.
Just a second, I want to, okay.
Yes, slideshow, please, yeah.
Yes, okay.
Okay, great, go ahead.
So my talk will be based upon the recent guidelines for the management of brain dead donors, their management in the ICU, and with the aim to improve the transplantable organ quality. As we know, there is a global shortage of donors, and a lot of big percentage, significant percentage of patients die, unfortunately, on the transplant list. And the supply, the organ supply, are much less than the demand. And over the years, despite even increasing the pool by procuring organs from living donors, despite that, we are in organ shortage. So the goals of donor management is the preservation and optimization of organ function in order to maximize the donation rate and improve the graft function after transplant, whether on the short term or the long term outcome. This can be achieved through preservation of the hemodynamics and the gas exchange, as well as the prevention early treatment of complications, whether ventilator-induced lung injury, infections, electrolyte disturbances, or endocrine alterations. In general, the management follows the same lines of management like other critically ill patients, but there are specific measures that should be undertaken due to the specific pathophysiological changes that happen after increased intracranial tension and brain death. However, all those recommendations for the management are based on the best available evidence are mainly observational studies with low quality, unfortunately. After the brain death, a lot of pathophysiological changes happen, causing hemodynamic alterations, systemic inflammatory response, as well endocrine changes and hypothermia. An autonomic storm happens due to increased intracranial pressure. And this brainstem injury and ischemia happens in a rostral caudal progression. Upon compression of the pons, there is sympathetic and vagus stimulation. The sympathetic stimulation causes increased blood pressure, and the vagal stimulation causes bradycardia, the Cushing response. As the injury progresses, there is compression of the medulla, and there is unopposed sympathetic stimulation causing the sympathetic storm. And after herniation of the foramen magnum, then there will be, with the brain death, there will be catecholamine depletion with sympathetic denervation and severe hypotension. From this diagram, we can see how the brainstem injury causes this sympathetic storm, affects the heart, affects the lung, causes hypertension, increasing afterload of the heart with arrhythmias, ischemia, stress cardiomyopathy, and reduced cardiac contractility, hypotension, and bradycardia. The lungs also are affected, and there is alveolar epithelial injury, and this can cause, in addition to the mechanical ventilation stress, pulmonary edema, whether cardiogenic or non-cardiogenic, and all those factors cause further a systemic inflammatory response with macrophage activation of the inflammatory and the coagulation cascade, and a vicious circle continues. So during the hemodynamic management, it's important to use short-acting drugs for blood pressure control during the hypertensive period and during this autonomic storm. Following brain death, the main problem is the hypotension. This hypotension is multifactorial. This shock is multifactorial. It has distributive, cardiogenic, and hypovolemic elements. So we have a distributive shock due to catecholamine depletion, damage to the vasomotor center, the systemic inflammatory response, as well as deficiency of vasopressin and cortisol. The heart also suffers due to stress cardiomyopathy during the sympathetic storm. And also always remember that there might be a pre-existent cardiac condition causing hypotension. Also, low thyroid hormone can cause cardiac dysfunction. Those patients can also become hypovolemic, whether due to the initial injury or when they develop diabetes insipidus, which is very common in brain death donors. This hypovolemia can also happen secondary to osmotic diuresis using mannitol or hypertonic saline, or due to severe hyperglycemia. So the recommendations for the hemodynamic monitoring is based upon the usual management. There are no large studies to guide us, but the usual management, the ECG and arterial blood pressure monitoring, we can assess the volume status using non-invasive monitoring like the pulse pressure variation or stroke volume variation. We can sometimes use invasive pulmonary artery catheter for measuring of the wedge pressure and the pulmonary artery pressure. Serial echocardiographies to assess the heart function, especially in cardiac donors, as well as to assess the cause of hypotension. And we also monitor the parameters of perfusion to ensure adequate organ perfusion. As you can see from this diagram, that many of the causes of hypotension in brain death patients are secondary to endocrine causes using hypotension with different mechanisms. So it is presumed that there is a depletion of vasopressin, thyroid hormones, as well as cortisol, probably usually central. But does this call for routine hormone substitution? The first and the most important endocrine abnormality is central diabetes insipidus, and those are the criteria for diagnosis. There is polyuria with high urine output, more than 3 to 4 liters per day, and this is associated with hypernatremia, increased serum osmolality, and paradoxically, inappropriately dilute urine. This condition happens in 46 to 86% of brain death donors, and if untreated, it will cause severe hypovolemia with hemodynamic instability. Severe hypernatremia also leads to poor liver graft function after procurement. The differential diagnosis is osmotic diuresis due to hyperglycemia or mannitol, and we can differentiate using the urine osmolality. The treatment depends upon the hemodynamic condition. If the patient is hemodynamically stable, then you can just give desmopressin, which acts on B2 receptors, causing antidiuretic effects. and the typical dose is 1 to 2 mic every 6 hours, and we target urine output of 1 to 2 ml per kg per hour. If the patient is having also hemodynamic instability due to concomitant vasoplegia, then the drug of choice will be vasopressin, which acts on all three types of vasopressin receptors, and the usual dose is 0.01 to 0.03. It is also important to do fluid resuscitation with hypotonic fluids in case of severe hyponatremia. It's been presumed that there is central hypothyroidism in brain death patients. However, in the majority of brain death donors, the TSH and T4 are normal. There may be a decrease in the free T3 with an elevation in reverse T3. Even when those brain death donors are followed over time, there is usually no decrease in TSH over time. We can compare those abnormalities to those patients with acute critical illness showing SCCU thyroid, who sometimes show normal or elevated TSH and T4. So, should we routinely treat those patients and give them T4 or T3? There is one observation study which showed that there is an increase in organ procurement rate in patients who received thyroid replacements. However, the graft survival was the same. Randomized controlled studies shown in this table, it showed no benefits. There was no impact on the donor hemodynamics or organ procurement rates, whether the hemodynamics are measured as the cardiac index or the inotrope dose used. However, those randomized controlled trials are not of high quality. They are underpowered. They included too many low-risk patients. And the consensus recommendation is to consider thyroid replacement only in hemodynamically unstable donors, especially if this is due to cardiac dysfunction. And the recommended dose for Eltroxin is 20 mic per IV plus as a bolus, with the maintenance of 10 mic per hour. Also, central adrenal insufficiency was presumed to be prevalent in patients with brain death. However, studies had shown that a lot of brain death patients have normal ACTH and cortisol levels. One study done in 2003 showed a decreased cortisol reserve shown by a low increase in total cortisol after exogenous ACTH testing. However, this decreased cortisol reserve we know it's prevalent and it can happen also in non-brain dead patients who are critically ill, and it is not necessarily associated with hemodynamic instability. And also the measurement can be inaccurate because in that study they did not measure the free cortisol, which might be lowered due to decreased corticosteroid binding globulin. One study conducted in 2014 was a prospective cluster study in 22 ICUs, and it showed they compared low-dose hydrocortisone, 50 milligram IV bolus plus 10 milligram per hour, compared with no supplementation, and there was increased weaning of the vasopressor support, significant, the duration and the dose. However, there was same organ procurement rates. The only benefit was in kidney organs, which showed delayed renal renal delayed graft function, so better graft function. So in conclusion, there is no routine hydrocortisone for presumed adrenal insufficiency. It is not recommended. However, there are some studies which showed that high-dose methylprednisolone can protect against early allograft dysfunction by inducing preconditioning. Those studies are, there are two types of studies. This is a systemic review. It compared observation studies with randomized controlled trials. Although there are a lot of observation studies which showed some benefit of steroids, but really in the randomized controlled trials, they showed no benefit, whether in the donor outcomes or the receiver outcome. The only study that showed benefit was in liver donors. And in this study, it included 100 liver transplants. They received 250 methylprednisolone bolus with a maintenance of 100 milligram per hour till recovery of the organs. And they claim to have decreased ischemic reperfusion injury with a decreased acute rejection. However, a similar study, although with a smaller number of patients, giving somewhat similar dose, 1,000 milligrams of methylprednisolone as a bolus, it didn't show any beneficial effect. So both studies are contradicting and both are small studies. Based on those findings, it is not recommended to give hydrocortisone routinely for such patients. Maybe giving high-dose methylprednisolone to prevent early allograft dysfunction in liver patients and lung patients can be given, but this is, again, low level of evidence. And the consensus recommendation is that if the patient is unstable, then we can give him hydrocortisone. We may consider methylprednisolone to prevent early allograft dysfunction. But before giving any steroids, it's important to remember that giving steroids may affect the HLA tissue typing. And remember to collect the blood samples before giving the hydrocortisone. Hyperglycemia is common in brain death patients, and it can cause poor graft function, especially in kidney and pancreas donors. And it can cause severe, if the blood sugar is very high, can cause osmotic diuresis and hypovolemia and hypotension. Again, there's no recommendation with an optimal target. There's no randomized controlled trials, and the consensus is to prevent and treat severe hyperglycemia. We don't go for tight glycemic control anymore. So no routine, the recommendation for endocrine treatment, no routine hormone supplementation, and we give endocrine treatment in only unstable or selected donors with vasoplegia, cardiac dysfunction, or diabetes insipidus, and we try to prevent and treat severe hyperglycemia. Next, we'll speak about the patients, another mechanism for hypotension in such patients, which due to hypovolemia. This requires fluid resuscitation. As we know that the kidney likes fluids. On the other hand, the lung needs happy lungs or dry lungs. So it's really might be challenging to reach the optimal fluid status. Again, there's no randomized control studies, and we have only observational evidence. But it shows that we can keep relative fluid restriction without affecting the kidney functions, and it is safe. So we can procure both the lungs and the kidneys. In one study done in 2013, it was a prospective cohort study in organ donors. They used a lung protective protocol including ventilator recruiting strategies, giving thal-prednisolone, and relative fluid restriction, targeting a CVP less than 8 with an extravascular lung water less than 10 ml per kg. And they compared this against historical controls, and they showed some benefits with a more lung procurement, and this was shown to be safe for the kidneys. The organ procurement and graft survival was good, and this is the survival of the kidney graft. And here they are comparing relative fluid restriction for the kidneys with historical controls, and it was even better. Again, the choice of fluids is controversial. There's only one randomized controlled trials in brain-dead organ donors, and it was comparing two types of colloids. It showed that there is worse outcome using starch. So, like general practice, it is recommended to use isotonic crystallized more than colloids. Try to avoid heterstarch and gelatins even. Maybe use albumin. If the patient is having hyperchloremic acidosis, it's better to use balanced crystalloids. And if the patient is having severe hypernatremia secondary to DI, then we use hypotonic solutions. As for blood transfusion, there again no randomized controlled trials, but following the general guidelines, if the patient is hemodynamically stable, then we keep the hemoglobin above 7 grams per deciliter. And if a patient is unstable with tissue perfusion, hypoperfusion, then probably we'll target a higher hemoglobin and hematocrit. As for the choice of the pressors, again, there's no comparative randomized control trials. A lot of pressors can be used in brain death donors, dobutamine, dopamine, epinephrine, norepinephrine, vasopressin, phenylephrine. And in this study, it's an observational study, there was the only difference that was shown is the number of pressors in relation to the heart graft survival. So if the patient was using no vasopressors before organ procurement, this had the best outcome, and with a relative risk of 1.26 in multivariate analysis. Again, the choice of the norepi of the vasopressor was shown in this study to have a higher, worse outcome using norepi. However, in further observation study, there was really no difference in the outcome depending upon the choice, the type of the vasopressor. In this study done in 2009, they studied the effect of donor pretreatment with dopamine, low-dose dopamine on graft function after kidney transplantation. They compared low-dose dopamine versus no dopamine, and dopamine was tapered or stopped if the heart rate was more than 120 or if there was high blood pressure. There was no direct comparison with noradrenaline, and one of the limitations that we cannot draw any conclusions about the effect of noradrenaline is that 78 to 85% were concomitantly receiving noradrenaline with dopamine. So in that study, the pretreatment with low-dose dopamine reduced the need for dialysis, more than one dialysis in the first week. This was the primary endpoint, but there was no, on the long-term follow-up, there was no benefit regarding the allograft survival. upon follow-up up to 3 years. The use of vasopressin is recommended in patients with vasopressin deficiency showing signs of diabetes insipidus with hypotension. It was shown again in observation studies to have increased organ procurement rate, but however, there is no randomized controlled trials to show benefit upon not giving or compared to other vasopressors. So we have insufficient data. Several combinations of vasopressins, catecholamines are being used in donors. We cannot establish the superiority of one regimen over the other. Dopamine vasopressin can be considered, norepi also can be considered. And in hemodynamically unstable donors, always remember high hormone replacement, vasopressin, cortisol, and thyroid hormones. The hemodynamic treatment goals is to maintain adequate organ perfusion with an adequate cardiac output targeting a MAP of 65 to 70. We follow up the classic parameters of organ perfusion, and we can use invasive, semi-invasive or invasive hemodynamic, non-invasive hemodynamic measurement devices. The target is to maintain the euvolemic state and avoid overhydration and underhydration. Overhydration is bad for the lungs. Dehydration and high sodium is bad for the liver and for the kidneys. We can use low dose of vasoactive agents and consider endocrine therapy in unstable donors. Those are the conclusion of the recommendations. In lung donors, it is important to remember that the lungs are damaged after brain death due to the sympathetic storm and alveolar injury, as well as pulmonary edema due to cardiac dysfunction and the systemic inflammatory response. In this study conducted in 2020, they compared a lung protective mechanical ventilation strategy compared with conventional mechanical ventilation. The lung protective, it was a small study, including 118 patients. The lung protective mechanical ventilation targeted a tidal volume of 6 to 8 ml per kg predicted body weight, not the actual body weight. It's very important to calculate the predicted body weight based upon the height of the patient. They applied a PEEP of 8 to 10. During the apnea test, they applied CPAP, and they all use closed circuit airway suction. And the last three parameters is to maintain the recruitment of the lung. This is compared by the conventional mechanical ventilation. I don't know if anyone is using still using such high tidal volumes of 10 to 12 ml per kg predicted body weight with a low PEEP, 3 to 5, disconnection during the apnea test, and an open circuit airway suction. The lung protective ventilation increased the lung procurement rate up to 54% compared to 27% in the conventional group, and this was significant.
Dr. Tarek, 2 minutes more, please, because still we have 3 lectures.
Okay.
Sorry.
Okay. Yeah. So for the respiratory management, use the lung protective ventilation, and this can also include relative fluid restriction, and try to monitor and treat any ventilator-associated pneumonia and apply a bundle. The nutrition, coagulation, and temperature management. Coagulation, those patients can have DIC. It can happen in 15 to 25% of brain death donors after traumatic brain injury. If the patient is not coagulopathic, then we use prophylactic low molecular weight heparin. We target an INR less than 1.5 and platelets more than 50. Those patients are really, the donors are at risk for nosocomial infections. And sepsis bacteremia is not a contraindication unless the patient is in septic shock with multi-organ failure. But it is important if the patient develops signs of sepsis to delay the procurement of organs for at least 24 to 48 hours of antibiotics. If the patient is presenting with a febrile illness of unknown origin, this is a contraindication. As for the temperature management, we know those patients are liable to get hypothermia due to loss of thermoregulation. And there was a randomized controlled trial comparing the effect of targeted hypothermia with normothermia. And really, it didn't show any long-term outcome benefit for renal patients, only a decrease in the dialysis need in the first week after transplant. So the consensus recommendation for treatment of hypothermia is to maintain temperature above 35, and if the patient is hemodynamically stable, to target a temperature of 36 to 37. So in conclusion, we lack randomized control trials as evidence to guide our recommendations. The general management is like other critically ill patients: hemodynamic stabilization, lung protective ventilation, prevention of infection and monitoring of that, thromboprophylaxis, maintaining normal blood sugar, and continuing to give nutrition. Parenteral nutrition is not recommended to be started early. And for the endocrine therapy, it is not routine for all patients. It should be tailored when indicated, and temperature management. Thank you and for listening. And if there are any questions and comments, I'll be happy to answer them.
I think in the interest of time, Dr. Tarek, thank you very much for an excellent presentation, but I do think we need to...
You're welcome.
It was, and that your primary reference is an excellent publication. One of my colleagues, in fact, was one of the authors.